Do it again. There we go. Okay. Hi, everyone. This is Lisa Letourneau with Maine DHHS, and we're very pleased today to welcome you all here today to learn more about the new Centers for Medicare and Medicaid Services and the Innovation Center, the new AHEAD model. And I will leave it to our presenters to remind me about exactly all the words that AHEAD stands for, because I can never get it quite right. But so we have many folks from Maine joining this webinar. This is in webinar mode, so folks could please use the Q&A function to record any questions. And then if anyone would like to ask questions afterwards, we can always unmute as well. With that, I'm going to just turn first and introduce, or let my state colleagues introduce themselves, and then our CMMI colleagues, and then we'll jump into the presentation, but we'll have plenty of time for questions and discussion afterwards. So Meg.
Good afternoon, everyone. I'm Meg Garrett-Reed. I'm the Executive Director of Maine's Office of Affordable Healthcare, an independent agency here in Maine tasked with improving the efficiency of the healthcare system in the state and increasing affordability for consumers. One of the office's charges is to monitor the use of alternative payment models here in Maine and across the country. So I'm very excited to be able to join this webinar and learn from CMMI and engage with all of you in the future about this model and others. Thanks.
Terrific. Thanks. And Olivia.
Good afternoon. Olivia Alford. I'm the Director of Delivery System Reform with the Office of Maine Care Services. This model has a heavy emphasis on Medicaid payment reform, which, as you know, is a priority of this administration. And we've been doing a lot of work with many of you around this area. So we're interested as well in learning about this opportunity.
Great. And I did want to note that Commissioner Lambrou sends her regrets. She was going to join us today. And I should also start out with a recognition of the incredibly sad and tragic events in Lewiston just a week ago. I'm sure our CMMI colleagues are well familiar as well, but it's just been an unbelievably horrendous week. And our hearts go out to all of our friends and families who have lost folks, and particularly to all of you in the Lewiston, Auburn area, and all the caregivers that have been directly involved in the response. So we note that with tremendous sadness. And again, Commissioner Lambrou is actually in Lewiston today, so sends her regrets. And with that, I will turn to Kate and then Christina.
Yes, good afternoon, and thank you all for being with us today. We're going to try to really make this worth your while, because I know everyone on this call is incredibly busy. We are supremely excited about the state's advancing all-payer health equity approaches and development model. My name is Kate Sapra. I am the director of the Division of Multi-Payer Models, which houses all of CMMI's, which is the CMS Innovation Center's state-based total cost of care models, including Maryland and Vermont. I've been working with states at CMMI for 7 years and really find that this is where the magic happens when we think about transforming the way that beneficiaries receive care, is really this partnership between states and the federal government. And so really excited to be able to talk with you all directly today about this opportunity. Chris?
Good afternoon, everybody. I'm Chris Kreider. I'm the Deputy Director for this division, and excited to speak with you all today.
So Lisa, shall I go ahead and get us started? All right, so I have prepared a few slides, and my goal is to give you just enough information so that you can ask questions. I want to make sure that we get lots of time to answer questions. Thanks to those of you who sent questions in advance. Chris and I are going to work together during the presentation today to inform you and also to answer questions. So without further ado, I will start sharing my screen.
And again, just a reminder, folks, to use the Q&A function down at the bottom to submit questions. That would be great.
All right. Trying to go into presentation mode here. Excellent. Okay. So I first want to start with an overview of what this model seeks to achieve. And it is wonderfully ambitious. We're really working to improve health outcomes for all residents within a state. And we at CMS are partnering with states, up to 8 states, to give flexibilities in exchange for a state's commitment to achieve total cost of care growth targets that are more sustainable than what we're currently on for both Medicare and all payers, to achieve primary care investments that will support a well-functioning healthcare system, again, on both a Medicare and all payer basis, and to achieve greater health equity and improved population health outcomes. So ultimately, that's what we're trying to test. And given how ambitious these objectives are, we are offering 8 to 9 performance years. And that is after up to 2.5 years of a planning period, which we call pre-implementation. So this is CMS's signal that we are truly committed to achieving these outcomes and supporting states by giving them tools in order to achieve those targets. So cooperative agreement funding is grant funding that CMS makes available to the state. This is really seed funding to support standing up the model. And as Olivia mentioned, there's a very heavy emphasis on Medicaid, given our interest in aligning all payers, and as well our interest in improving equity. And so this cooperative agreement funding goes to support the state's efforts to stand up the Medicaid portions of the model, as well as other requirements of the state. We also offer hospital global budgets. And I'm going to talk more about this, and in particular, the Medicare fee-for-service methodology in a little bit. But this really allows hospitals the flexibility to invest in population health in a really radically different way than fee-for-service. Primary Care Ahead is our primary care program, and it really seeks to bring Medicare dollars to align with ongoing Medicaid patient-centered medical home models or other primary care alternative payment models ongoing in the state. And this serves as increased investment in primary care, which we know is associated with better health outcomes. Embedded across everything that we do in the model is a focus on equity, integrating behavioral health, bringing all payers to the table and aligning closely with Medicaid, and really accelerating existing state innovations. So this model is designed to be very flexible. And as I mentioned, we'll be making awards to up to 8 states. And so we really want this to work in a wide range of states, high-cost states, low-cost states, states that are more rural, states that are more urban. And I'm going to talk a little bit more about each of these different components. On the all-payer side, the state is committing to achieving primary care investment and total cost of care growth targets on an all-payer basis within the state. On the primary care investment target, these must be memorialized in an executive order or state legislation by the first performance year. And you may recall that there's up to 2.5 years of planning available to states, during which time they will convene stakeholders and establish these EOs or legislation for investment targets. It builds on existing state progress and can be informed by our Medicare fee-for-service methodology. And all payer truly does mean all payers, Medicaid, commercial, and Medicare. On the total cost of care targets, again, we are requiring that these targets be memorialized in an executive order or legislation by the first performance year. And it builds on the existing cost growth efforts underway in certain states And at the bottom, I referenced the Peterson-Milbank program for sustainable healthcare costs. Importantly, I want to note in particular for our Medicaid colleagues that we will not penalize states for increased Medicaid beneficiary coverage or access to services under the total cost of care targets. We also have a number of quality and equity targets under the model. The state must develop a health equity plan and must select from measures in 5 domains around population health, prevention and wellness, chronic conditions, behavioral health, and healthcare quality and utilization. In addition, all states must select at least one optional measure from the domains of maternal health, social drivers of health, and prevention. Within each of these, the states will also use data to establish targets for reducing disparities. We know that these disparities will be different by state, and so we've not been specific about whether these are based on geography, race, ethnicity, language, or some other characteristic. Now I'm going to go into more detail on the hospital global budgets. As we've been talking with stakeholders about the AHEAD model, we found it's very much necessary to clarify what we mean about a hospital global budget. These are built bottom up from past net patient revenue within the facility, inpatient and outpatient, including hospital outpatient departments. And for those of you who were engaged in thinking about the chart model, I want to note that this is a specific departure point from chart. So in AHEAD, it is really based on a hospital's historic revenue on the Medicare fee-for-service side. This historic baseline is fixed, but then we make annual adjustments for inflation, demographic changes, and service line changes. And really our goal here is to support hospitals in transforming care delivery and shifting utilization to primary care and community-based settings where appropriate. And again, this is very different from chart. And so I want to talk a little bit more about some of the incentives for hospital participation. We have initial investment to support hospital transformation in early years of the model. And I'll talk a little bit more about this, but again, this is going to mean an upward adjustment on Medicare fee-for-service. Increased hospital financial stability and predictability when revenue is decoupled from fee-for-service, which is one of the hallmarks and something that we've seen has been really important to hospitals in Pennsylvania and Maryland in particular during the COVID-19 public health emergency. Hospitals have the ability to share in savings from reduced potentially avoidable utilization and more efficient care delivery. And I'll talk a little bit more about that. There's an opportunity to earn upside dollars for improving health equity and quality while contributing to the population health of the community. There's also the potential to use waivers to support care delivery transformation and engage non-hospital providers, and an opportunity to participate in learning activities to facilitate success under the global budget. As the name suggests, this is an all-payer model. The way it looks, though, is that each payer will have a hospital global budget that is paid directly to the hospital. So Medicare fee-for-service will have a global budget, Medicaid will have one, MA and commercial payers will all have a global budget paid directly to hospitals. Now, please forgive this busy slide, but I do hope it is helpful to provide this overview. On Medicare fee-for-service, there are some states that have existing rate setting or hospital budget authority, and they can set their own methodology. However, I want to note that states are not required to have all payer rate setting authority to participate in the AHEAD model. States without these authorities, like Maine, would use CMS's designed methodology. And this global budget methodology will be implemented in the first performance year. For Medicaid, The state Medicaid agency is responsible for developing their own hospital global budget methodology in alignment with principles outlined by CMS. We at CMMI, in collaboration with our colleagues at the Center for Medicaid and CHIP Services, will review and provide technical assistance on the Medicaid methodology. And those will be approved through normal regulatory processes. These global budgets must also be implemented during that first performance year. On the commercial side, we believe that having commercial payer participation will increase the likelihood that hospitals will also participate. And so we are requiring at least one commercial payer must participate in global budgets by the second performance year. So CMS is not going to require hospital participation. This is a question we often get. Hospital participants must be Medicare enrolled facilities in good standing with CMS and located in the participating state or substate region. This includes acute care hospitals, critical access hospitals, and for states that enact enabling legislation, rural emergency hospitals. Something to note, at least 10% of Medicare fee-for-service net patient revenue within the state or substate region must be under a hospital global budget by the start of the first performance year for the state to remain in the model. This will increase to 30% by the start of the fourth performance year. So I'm going to go into a little bit more detail on the global budget methodology and Medicare fee-for-service. Again, the overview is really that CMS uses a hospital's historical revenue for eligible hospital services, combining 3 years of historical data and weighting the most recent years more heavily. We then apply annual adjustments. So this will include things like the wage index, inflation, demographic shifts in age and population size, and hospital shifts in services. We also offer AHEAD-specific adjustments, which I'll detail on the next slide. This historical revenue plus annual adjustments results in the global budget payment. For Medicare fee-for-service, we will offer prospective biweekly payments in place of fee-for-service claims. This is also in place of cost-based reimbursement for critical access hospitals. I will note, though, that CMS plans to have a floor for critical access hospitals of cost-based reimbursement. More detail will be available in early 2024. So here are the AHEAD-specific adjustments. The Transformation Incentive Adjustment is CMS's early investment in hospital transformation. It's an upward adjustment in the first 2 years of the performance period of the model. We will also have clinical and social risk adjustment, likely based on HCC, area deprivation index, dual eligibility, and Part D low-income subsidy status. We also offer a health equity improvement bonus, which is an upward adjustment based on hospital performance on disparity-sensitive measures. Quality adjustments will continue as usual for PPS hospitals, and we're offering an upside quality option for critical access hospitals under the AHEAD model to reward critical access hospitals for providing outstanding care in their communities. The total cost of care performance adjustment is an upward and downward adjustment based on the total cost of care incurred by beneficiaries residing in a hospital service area, phased in over time. And this is really to align all providers, including hospitals, in thinking about the continuum of care for beneficiaries and ensuring that care is being provided efficiently. The effectiveness adjustment is a downward adjustment based on a portion of the hospital's calculated avoidable utilization. This is phased in over time, and the hospital retains any savings beyond that adjustment. I'm now going to spend a little bit of time on primary care AHEAD. As I mentioned at the beginning, it's designed to be flexible enough to align with each state's Medicaid primary care goals and brings Medicare to the table for increased investment. We want to support advanced primary care, including advancing behavioral health integration, care coordination, and health-related social needs, screening, and related activities. We also want to ensure that all types of providers can participate. This includes FQHCs and, for the first time in a CMMI model, rural health clinics. Right now, and what I will describe on the next slide, is essentially a care management fee-based program, but in the future, we're committed to offering a capitated track for primary care. Primary care practices within the participating state are eligible to participate in primary care ahead as long as they also participate in the state's Medicaid primary care APM or PCMH during the same year. Hospital-owned practices are only eligible to participate in primary care ahead if the affiliated hospital is also participating in that same year. We do have an exception, though, for FQHCs and RHCs. So what is the payment mechanism in primary care ahead? It's an enhanced primary care payment, or EPCP. On average, participating practices will receive $17 per Medicare fee-for-service beneficiary per month for attributed beneficiaries paid quarterly. A small portion of this payment is at risk for quality performance. As I previously mentioned, practices must participate in the state's Medicaid PCMH, and they must meet specific care transformation requirements, which will be aligned across Medicaid and Medicare. These dollars are flexible and can be used to invest in infrastructure and staffing to perform advanced primary care. These are the care transformation requirements at a broad level. And as I mentioned, it really focuses on behavioral health integration, health-related social needs screening and coordination with community-based providers, and greater care coordination, including formalizing specialty referrals through e-consults and aligning referral systems across Medicaid and Medicare. I do want to spend just a few minutes talking about the additional model strategies and components. Health equity is core to this model. We have developed this in alignment with CMS's framework for health equity, and our strategy is multifaceted. As I mentioned, states must develop a state health equity plan and establish quality targets. We seek to enhance partnerships between the state, providers, and the community to meet model goals, including through a model governance structure that is responsible for establishing the state health equity plan. We aim to increase safety net provider recruitment into the model so that more beneficiaries, particularly those in underserved areas, can benefit from the model. We're using social risk adjustment to increase the resources available to those caring for the most vulnerable, and ensuring that health-related social needs screening is part of our model strategy. As I mentioned on the previous slide, we do have a requirement for a model governance structure. This body must have a role in model implementation, though it could be advisory. And states may build on existing boards to meet this requirement. We do require patients and/or advocacy organizations and community-based organizations be at the table alongside payers and provider organizations. Local tribal communities, where applicable, state Medicaid agencies, and state public health agencies must also participate. The model governance structure develops the statewide health equity plan and provides input on the state quality and equity targets. They review and support hospital health equity plans and can provide input on the cooperative agreement investment. We also have an emphasis on behavioral health integration throughout the model. As I mentioned, we have waivers. These are Medicare payment waivers to support greater access to behavioral health. We require the state to select at least one behavioral health specific equity goal, and also quality measure related to behavioral health. As I previously described, primary care ahead practices must integrate behavioral health as part of their care transformation requirements, though I will note this does not necessarily mean co-location. And additionally, states may use their cooperative agreement funds to support behavioral health infrastructure and capacity building. Brings me to the end, so I will stop sharing and see if there's anyone that would like to come live and ask their questions.
Great. Well, thanks so much, Kate. Really helpful. Again, it would encourage folks to use the Q&A function. I saw that folks already have, and Christina is dutifully answering questions that way, but we probably should just call them out for the group. And then I know that several folks had submitted questions ahead of time as well. And then people can also let me know, I guess, raise their hand. How do they let me know to unmute? We can unmute folks if they want to ask questions, but or my colleagues remind me, how do I know that they want to unmute? They raise their hand? I guess so. Okay. So I see one hand raised. Why don't we take Craig's question right now as soon as I can find him. And then maybe take the questions that folks have sent in and then go through the Q&As as well. And I apologize, I'll encourage any of my co-hosts, it says Craig has raised his hand, but I'm not finding Craig in the list to unmute.
I think I can do that. Oh, okay, there we go.
Oh, great.
Okay, can you hear me?
Yes.
Okay, thank you for that presentation. It's really good. The other thing, one of my questions on here, I asked the social risk adjustment question, and you answered that. But another question I have is, MCP, or Making Care Primary, has a lot of detail on primary care payment, and I'm curious how AHEAD will align with that. I know it's going to be flexible to align with state, but what you're tipping your hand on the fee for service for Medicare is that there's going to be some enhanced primary care payment. So that's kind of like, I translate that to infrastructure type of payment, right? There's a little bit of risk to it. But I'm wondering, just like Making Care Primary, will you also add performance improvement payment on top of that? So they have significant infrastructure payment on Making Care Primary, and then they also have the ability to earn through performance improvement payments. And I'm wondering if AHEAD will do the same thing.
And can I just tag in behind that one to ask for clarification, Kate, because I think I missed this initially as well. I had understood that CMS had invited 8 states to participate in Making Care Primary. It sounded from your presentation today that that's separate from that the different 8 states, or whatever 8 states chosen to participate in AHEAD, CMS will be using the Making Care Primary methodology in that as well. I didn't catch that before. So sorry, Craig, I just want to clarify that.
Thanks so much for the question. So we do have a coordinated primary care strategy across the center. And so there are certain things like wanting to ensure that we're increasing our investment in primary care, wanting to ensure that social risk adjustment is part of the payments. All of that is the same across Making Care Primary and Primary Care AHEAD. But there are important differences among them. So just a technical note is that Making Care Primary states and AHEAD states have to be geographically separate. 7 of the Making Care Primary states are operating statewide, so AHEAD cannot operate in those states. There's one state, New York, that's only operating MCP in part of the state, so AHEAD could operate in the other part of the state for New York to apply and be selected. So that's just like technical piece. But in terms of the actual payments, so Making Care Primary has sort of advancing tracks. Right now, Primary Care AHEAD is just essentially a care management fee on top of fee for service. We are developing a capitated track. We are hoping that that will roll out in 2027, which is likely to be the first performance year for most states. The earliest states could start a performance year is 2026, but recognizing that we're almost at the start of 2024, that's pretty ambitious for most states. And so the capitated track, you know, I think we'll see what's working well in MCP and learning from other models that have had capitation at the center, including Primary Care First, the Maryland Primary Care Program. So we have lots to draw on. But in general, really wanting to make sure that we have sort of a unified strategy across the center. Something else that is the same about making care primary and ahead is the inclusion of federally qualified health centers. Something that's different about ahead is that we include rural health centers, and making care primary does not. On the payment, our enhanced primary care payment is actually larger than the infrastructure payments in making care primary. So we don't have like an improvement bonus on top of the PMPM because our base PMPM is already higher than making care primary. Chris, anything else that you think I should note, or Craig, if you had another question that I haven't quite answered?
No, thank you for that.
I think just to address some of the questions in the Q&A boxes, the $17, the average of $17 per member per month is for Medicare fee-for-service attributed lives. Primary Care Ahead has been designed to align with what's already happening on the ground in state Medicaid primary care initiatives. Or if the state is not already actively engaged in primary care initiatives, either a PCMH or other Medicaid primary care alternative payment model, then they would be required to implement under the model. And so, so this $17 brings Medicare to the table to align with what's happening in Medicaid, and is just for those Medicare fee-for-service attributed lives. And similarly, commercial payers would be encouraged to align with what Medicare and Medicaid are doing as well. So I think that answers the two questions about the PBPM. And then in terms of the question about high deductibles and payer denials of care, including testing and medication. So again, I don't know if that, oh, Kate, did you? Oh, okay, sorry. So in terms, I don't know if that's specific to hospital care or primary care. I will say, so the model, the PBPM for the primary care component does not have a copayment or deductible attached to it. However, patients would still be subject to the copayments and deductibles under Medicare fee-for-service that they are currently. Participating providers may have opportunities for flexibilities in terms of waiving copayments for beneficiaries under the model. Similarly, for hospitals, they would have flexibilities to waive copayments, though that would come out of sort of their hospital global budget payment. So it's not additional Medicare funds to pay for the beneficiary copayments. It would be the hospital sort of contributing that for the beneficiary. And then in terms of commercial payers and Medicaid, that would really be up to the state and the payers to consider any changes in terms of prior authorization or deductibles that might want to be made under this model in alignment with the goals of the model. So I hope that helps answer that question. The question on logistics of healthcare delivery, I'm not sure exactly what you're getting at there. I will say that the model, all components of the model, the hospital global budget piece in particular, and the primary care pieces in particular, are built off of the evidence base, a lot of CMMI model history, but also other evidence base from alternative payment models and our long history of engagement with states there. So I would say that is the bulk of the experts that we have been working with. I don't know specifically what you mean about healthcare logistics.
I don't know if this is what the person meant, but I'll jump, maybe this is what they meant. Is there any practice transformation support provided from CMS directly, or is that something that states would build in as part of their cooperative agreement funding?
Yes, there's a learning system that is a part of the model, and the learning system is both to support states and peer-to-peer learning among states, as well as provider participants to share lessons learned, similar to some of the past CMMI models that include learning systems for providers.
Great. And then you also wanted to add an answer to the logistics issue?
I'm mostly managing the QA for Chris, so as she's answering them, I'm clearing them. But yes, I think the learning systems are very robust. So we're going to have learning systems for states, for hospitals, for primary care providers, because that is absolutely a learning of CMMI over the past decade. Is there's a lot of support that needs to go into the transformation, because it is it's not rocket science, but it is something that does take resources to do. And that's part of why we're also offering this cooperative agreement funding as really seed funding to the state.
Great. I did want to give an opportunity to answer some of the questions that folks took the time to send in questions ahead of time. Would that be okay to, no disrespect to those who are chatting online, which is great. We'll try to get through all of them. Would that be okay to look to some of those?
Sure. So we had one question come in. Can sub-state regions be organizational as opposed to geographic? So the answer to that is no. A state must designate a sub-state region based on zip codes. Under the model, CMS is testing accountability for total cost of care and population health of an entire geographic region. So it's broader than a single healthcare system. However, depending on the healthcare system within a zip code and sort of the market share of that healthcare system, it is, potentially possible that the state could designate the region within which a single healthcare system operates. And if that system has most of the market share, it feasibly could be just a single healthcare system participating in the model.
But to be clear, we wouldn't exclude others. If there's others serving care beneficiaries in that region, they would be welcome to participate as well.
That's right. So the state will designate the sub-state region within which it is participating, and that sub-state region will dictate sort of the total cost of care targets. So all Medicare fee-for-service beneficiaries residing in that sub-state region will go into the calculation for the Medicare total cost of care targets, and similarly for the all-payer total cost of care targets. All residents residing in that region will go into that, and the same for the primary care targets and the population health and health equity goals. And then all hospitals located within that sub-state region are eligible to participate in hospital global budgets, and all primary care practices located in that sub-state region are eligible to participate in primary care ahead.
Okay.
We had a question about the model governance structure. How far-reaching does the governance extend? So the governance structure is intended to be, at the very least, an advisory body that provides input and is consulting with the state as the state makes decisions about model implementation, and in particular in developing the statewide health equity plan, the statewide quality and equity targets, and in how the $12 million cooperative agreement funds are spent. So that's the minimum in terms of the charge of that model governance structure. And then there's also requirements around the composition of the model governance structure to ensure that it is representative of the region. There was a question about if a hospital participates or a regional rural health clinic participates, does that impact the status as a critical access hospital or a rural health clinic? And the answer to that is no, it will not affect those designations. And just to provide a finer point on it, the hospital global budgets will replace the hospital inpatient and outpatient facility fees. The status as a critical access hospital, for example, will not change. However, under the model, critical access hospitals will not be reconciled back to cost. There will be some safeguards in place. I think Kate mentioned some of the adjustments specific to critical access hospitals for upside adjustments for quality and some other opportunities for upside adjustments. There's also a floor to ensure that the critical access hospitals and other safety net hospitals global budget payment amount is at least what the critical access hospital would have been paid under a cost-based reimbursement. We had a question come in prior to the webinar about critical access employed clinicians who are historically exempted from alternative payment models and often don't necessarily have the same incentives that providers participating in value-based models enjoy in terms of changing the way they deliver care and rather relies on altruism and duty to change the way they are practicing, which I think there's concern around the impact of that on quality and access as well as recruitment. And so I think similarly to what I just shared about the way critical access hospital payments will change under the model. So the global budgets, again, provide these strong incentives for changing the way care is delivered and how hospitals think about care delivery. However, the global budgets will not change critical access hospital employed clinician payments. So the hospital global budgets don't directly change payment for professional services, but again, does incentivize hospital transformation and incentivizes changes to the way hospitals partner with clinicians and with community partners, including those employed hospital-based physicians. Additionally, critical access hospital employed primary care clinicians would be eligible to participate in primary care ahead. So there are a number of opportunities for clinicians practicing or providing services in a critical access hospital to benefit from some of these incentives under the model. There was a question about the defined population for a hospital global budget and how that is determined. And so just want to reiterate some of the points that Kate made earlier, especially making distinctions about the approach in ahead to how the hospital global budget payment amount is determined compared to potentially what this questioner was wondering about is the similarities or differences with the chart financial specifications. So in terms of the defined population for the hospital global budget, the capitated payment amount or the hospital global budget payment amount is not based on a defined population, rather it's based on historical revenue. CMS will attribute a population to the hospital based on geography for the purposes of holding the hospital accountable for those beneficiaries' quality. So Kate mentioned the critical access hospital quality adjustments. PPS hospitals will also continue to be accountable for quality under the national hospital quality programs. The national hospital quality programs will not change, but for the critical access hospitals, those quality measures, will be based on specific populations. Similarly, for the total cost of care adjustment that Kate mentioned, we will use this geographic attribution to attribute a population of beneficiaries to the hospital. But the total payment to the hospital is not determined based on the attribution, just those two adjustments. And then, there was a question about how that defined population is determined for tertiary hospitals that have large catchment areas. So for beneficiaries that reside in the primary service area of multiple hospitals, sort of that beneficiary will be divided among the hospitals based on market share. And I think that is it for the questions that came up before the webinar. So I will go back to the Q&A over here. And so
If I could
go
just
ahead,
interject a
Lisa.
minute. So, well, to compliment you guys are being incredibly efficient on answering. I don't think I've ever seen anything this rapid fire. It's amazing. So for folks who have typed in your questions, thank you. Hopefully you're seeing the tabs that they have answered between Kate and Christina. They have answered most of them so far. So please go ahead and check that and feel free to, again, raise your hand if you want to unmute and ask anything additional. But yes, there's 3 open still, so I'll go back to that. And we will share someone's asked, we'll certainly share the webinar, and I'm sure there is a way for us to share this log of Q&A as well.
To give Chris a quick break, I'm happy to take one that I think is maybe a little bit more directed to us at the state level, from Jess Sanford asking about authority that Maine would have to encourage participation by commercial payers. I think it's fair to say nothing about this model kind of confers any new authority on the state to do that. I think we're interested, as we are on the provider side, in having conversations with commercial payers about interest in this model and participating. And I know in some of CMS's releases on this, there's been discussion or consideration of different models, like working with a state employee health plan or working with marketplace carriers that already have a significant relationship with the state. So no new authority there, but a few different options on the table potentially to encourage or foster participation.
Great, thank you. And Meg, if you wouldn't mind just typing a brief version of that into there, that way we'll capture it for the log as well.
Sure.
So I think we're down to just 2 after that.
So there's a question about the Medicare hospital global budget payments. They include facility payments for hospital inpatient and outpatient services, which could include hospital outpatient departments off campus, and also confirming that the Part B professional payments are excluded from the hospital global budget. They would continue to be paid fee for service. And then last is a question about Medicare Advantage. And so not sure I understand exactly what the question is with regard to the consideration of.
I think it's that so many people are now in Medicare Advantage. I mean, we're upwards of 50%, that it makes it hard to reach that 10,000 in traditional Medicare as the benchmark for participation. I think I'm saying that right, Mary.
Okay. So I don't actually know what the number of Medicare fee-for-service lives in Maine is. I do agree with you that it is possible, it can be tricky to meet that 10,000 beneficiary threshold if the region is too small. But I think an important thing to consider here is that, one of the reasons we have this 10,000 beneficiary criterion is one, just for stability in the payment methodologies, but also in thinking about sort of patterns of care for beneficiaries, wanting to ensure that we're capturing a population of beneficiaries inclusive of the entire continuum of care within which that beneficiary will be seeking care, so that sort of it's all of the providers with whom that beneficiary will engage over the course of their care seeking could potentially be in the model. And so if the region is too small, then there's a higher likelihood that the beneficiaries will be seeking care outside of the participating region. And we really want to ensure alignment of the incentives across the model by trying to draw those boundaries in a way where we're including all of the providers from whom a beneficiary may seek care. So that doesn't necessarily answer the question about MA. I realize that in many states, the penetration is growing significantly. And I would just say that Medicare Advantage plans are encouraged to participate in the model and to offer hospital global budgets to hospitals participating in the model, similarly to any commercial payer would be encouraged to participate and to align.
Though, to be clear, Christina, even if we were successful in convincing or engaging one or more Medicare Advantage plans to participate, those enrollees do not count towards the 10,000.
That's right. That's fee-for-service beneficiaries specifically.
Okay. Wow. Again, you guys did an amazing job.
Does anyone have follow-up on any of the questions that were answered in the chat? Happy to dive in deeper into any of those questions or any follow-up.
Looks like there's one new one. Does the model have consideration for changes or alignment with providers in the post-acute space?
Yeah, the model will offer the opportunity for participant hospitals to benefit from some flexibilities and waivers under Medicare, and in particular in allowing Medicare to partner with post-acute care providers and to share resources and financial incentives with those. But in terms of engaging with post-acute care providers, for a direct payment model, that's not currently within the scope of the model. It's more engaging with them as aligned care partners under the hospital global budgets and aligning incentives in that way.
Great. And a new one. How vulnerable is this initiative to a change in administrations?
I think that we've designed this model in such a way as that there is, I don't think it's inherently political. It is a long model, and I think that there's broad support across both the administration as well as staff level folks across the department and all of our partners within the government who approve these types of models. And so, I don't have a crystal ball. I can't predict things, but I think sort of the nature of the model and the broad scope of the model and the broad support that we've seen among states who are interested, sort of lends the model to longevity. And I would point to some of our past models, like the Maryland total cost of care model that has been in operation since 2014 and has spanned 3 administrations now. I think, but when the model is as broad as a model like it had, or the Maryland total cost of care model sort of abruptly ending or changing the model is incredibly disruptive at the state level, as well as nationally. And I think that also helps to provide some protection against changes based on administration changes.
Terrific. How about just a little bit more? I know I had shared with you all ahead of the call a probably overly long, but a summary of concerns that providers here in Maine had about the earlier chart model. And if folks don't remember, a chart was a rural hospital model that we didn't get anybody from Maine who was interested, and there were a lot of concerns. So clearly not enough time to go through every question, though just for folks on the line, both Christina and Kate have been very kind about looking at the chart that we initially had created and trying my best shot at trying to answer how ahead is similar or different. So we will share that with you all once we get through that. But any other big differences you want to call out between the two? You've talked a bit about the global budgeting, how that's different.
Yeah, thank you, Lisa. I think in reading through the feedback initially provided by Maine, the biggest and highest level concerns were really about the amount of risks and unknowns in the concerns that hospitals had participating in the model, given that. And I think Kate addressed some of the hospital global budget design considerations that we've built into AHEAD. A number of them specifically in response to the types of feedback we got on the chart methodology, flagging the amount of upfront risk as a big concern. And so things like the transformation incentive adjustment, which will provide an upward adjustment in the first 2 years of a hospital's participation in the model, are directly in response both to lessons learned we've seen in Pennsylvania and Maryland, where that upfront investment really is necessary to support the hospitals to invest in transformation and invest in the way they're delivering, in changing the way they're delivering care and in hiring staff in order to succeed under the model. But also about that upfront risk and needing some additional time to be able to bring some of that avoidable utilization under the out of the system and succeed under the financial approach of the model. I think another, and there are a number of other adjustments that similarly have sought to address some of that feedback on the model. And I think the approach to critical access hospitals similarly addresses some of the feedback we've heard about risk. And I think the other concern that really stood out to me in looking through that chart was that it was too focused on hospital costs and payments versus total cost of care and other partners across the system. And so this model, obviously it has accountability for total cost of care at the state level and really looks to align all providers and incentives toward a single set of population health goals. And it creates incentives for hospitals to partner with care partners across the system. It brings primary care providers in a way that the chart model did not. And it also, focuses on a much broader population, as I mentioned earlier, so that those incentives are in place for providers to be partnering with the entire spectrum of care delivery partners and over the entire sort of journey of a beneficiary's care journey. I think those were the two major ones that stood out to me. But if there are other areas that would be helpful to address sort of the differences, I think we've also talked about the attribution approach that's different, which was another very technical concern that folks had. But in general, sort of extrapolating on that attribution concern, we also heard a lot of concerns about the complexity of the hospital global budget methodology overall. And we took that to heart as well. And it's not simple. Medicare payments are never going to be simple, and value-based care payments are never going to be simple. But we are hoping to be as transparent about the methodology, to share it as early as possible with prospective participants, and to have it be, as understandable and comprehensible and aligned with the incentives of the model, so that it makes intuitive sense as much as possible.
Great. We are getting close on time. I did want to underscore one point, though, that you've referenced directly and indirectly several times, which is you have learned a lot from your experience. I think many hospitals understandably say, we're so strapped, things are so hard, this is too risky, we're going to go out of business if we do something like this. And I think it's fair to say that between Maryland, many hospitals, and Pennsylvania, the rural hospital demonstration, I'm not aware of any, I probably shouldn't say this, but I'm not aware of any hospitals that have gone out of business or had to close because of their participation in new models like this. Is that correct?
Yes.
Right. Yeah. So, I don't think CMS is doing this to try to threaten the financial viability of any hospitals. It's truly trying to move things forward in a different way and make things better. So I just wanted to underscore that. And I think you clearly experience with other parts of the model as well from your various initiatives that are out there. So it is 12:59. We're going to have to wrap. Just a huge thank you again, Christina and Kate. I honestly have, with all due respect to many other CMS and CMMI calls, I've never seen anybody so good at answering questions on the fly like that. So that's terrific. Thank you. To everybody else on the phone, thanks so much for joining. We will share, because you all had to register to attend, we'll share the slides and the Q&A log. And then eventually, when I can figure out where to post it, the recording of the webinar as well. We're also going to follow up with a survey at some point sent out broadly to Maine healthcare stakeholders to try to get some sense of interest in this. As you all know, the state has to be the applicant for this. And while we are very interested in it, we also need to know that partners would be interested and willing to participate. So we will be following up with a survey and other communications to try to assess that interest, and certainly encourage any of you to reach out to me or Olivia or Meg. We all follow the standard state first.last@maine.gov email. I think you know how to reach any of us. So again, thank you to you all, and Christina and Kate for your leadership on this. Thank you.
Thanks for having us. Have a great day. Bye-bye.
Bye.